Hi, I am Dr. Nitin Adusul from Sir Gangaram Hospital, New Delhi. The topic of my presentation is positioning of cervical spine surgery tips and tricks. So we'll discuss mainly about the position of the patient and the few points about the ergonomics and the position of the surgeon during the surgery. The flaws in the current system is there is no mention about the position related complication in any of our informed consents. So we'll discuss about the main points and the goals of the positioning. The main goal is to maintain the patient's airway, to maintain the circulation, to prevent the nerve damage, to provide adequate exposure of the operative field, to provide the comfort and the safety, maintain the patient's dignity, stability, and the security in the position. The cervical myelopathy and the patients with the high canal compromise, usually the extension causes more harm to the spinal cord. And during the intubation, it is very important not to extend the patient's neck as it causes the pressure on the cord. So this is the small video demonstration of the intubation of the cervical myelopathy patient. We usually use the CMAC so that there is no movement at the neck. There is only movement at the jaw and the video assisted intubation. Cervical spine surgery includes the prone position and the supine position. There are various tables available at present in the market. The Siemens positioning system, the Andrew frame, Wilson frame. We usually use the Wilson frame, then the Jackson spine table and the longitudinal bolsters. So out of these, the Jackson frame is having the minimum effect on the cardiac function. So the few points about the supine position, the bolster has to be beneath the neck and the interscapular region. The head has to be well stabilized and good padding over the occiput. We prefer a gel pad below the occiput, release the pressure on the occiput. The neck has to be slightly extended, tap the chin for the extension and avoid excessive extension of the neck and avoid the pressure on the nasal cartilage. The shoulder, the longitudinal traction should be there with the surgical tape to see all the levels in the fluoroscopy as shown in the CM picture and avoid the excessive traction. Then the arms should be along the side and tucked, knee should be flexed and the pillow should be under the knee. So this is the one more modification, and these bone foams are now available in the market. So it has the custom made interscapular pillow. Then it also has the support for the knee. It also helps in the traction of the patient during the surgery. So in the supine position, the calcaneum, olecranon, sacrum, thoracic vertebra, scapula, and the occiput has to be well padded. In a few conditions like cervical facet dislocations, cervical deformity, and cervical corpectomy cases, we need a cervical traction. In a prone position, we usually use a smart click. That is you can use your mobile phone in the selfie mode and take a picture of the patient during the prone position to make sure that there is no pressure on the eyes. The table head end has to be slightly elevated. So there are various positioners are available like prone foam based, safety faced piece, the horseshoe, headrest, and the Mayfield tongs. So out of which the Mayfield tongue is the most stable recommended in the cervical disc disease. In prone position, avoid direct pressure on the eyes. Cut out for the eyes, nose, and the mouth is important. So this is one of the modification done by the Oxford University. So if the patient is having surgery more than the 6 hours, they usually do a bactigras dressing before positioning the patient into the prone position. That helps to avoid any pressure sore. We have slightly modified this Oxford method by using the cotton above the horseshoe. It has helped us a lot in reducing the pressure sore on the chin and the forehead. The neck has to be slightly flexed. Check the endotracheal tube frequently, and proper padding is important. Our anesthetic, they usually use a torch because if the curtain is on, then it's not possible to check the eyes and the neck position. The shoulder and the upper limbs, pull the upper limbs longitudinally, bolster below the chest and the iliac crest, arm by the side. The abdomen has to be free. Avoid excessive traction on the shoulder, the proper positioning of the arm to avoid the peripheral nerve palsy and avoid the pressure over the genitalia in the males and the breast in the females. In lower extremity, keep the knees flexed. There has to be a pillow below the ankle and the good padding below the knees, and never forget to check the distal pulsations. There are few important pressure points in prone position like forehead, chin, elbow, genitalia, and the knee, and also there is anterior pelvic bones. So one more important point about the Mayfield head holders. The most of the standard tables, they come with the Mayfield head holder, which is having the metallic attachment in the front. So it is not possible to take AP X-ray with this head holder. You can take a lateral X-ray with this. So now we have come across this complication. The one screw of a 7-seater was medially placed. So we have done this modification of 3-point plaster traction which has been published. So only on the routine horseshoe we can position the patient and the strap the patient, and you can do the cervical posterior procedures like cervical foraminotomy, the laminectomy, and the cervical laminoplasty, as well as the lateral mass screw fixations and 7-C2 as well. And you can check both AP and lateral views. And there are few modifications in this, and the locally available radiolucent Mayfield head holders are also available in the market. The one more position is the lateral position, which a few surgeons prefer. That is, table is tilted at 10 to 15 degrees. So according to these authors, the in lateral position, you can the visualization is more better of the contralateral side in the cervical laminoplasty patients in lateral position. And when the patient is in sitting position, like few surgeons prefer it while doing the cervical laminectomy, laminoplasty, and the fixation cases. So when sitting, the surgical field is above the level of the heart, which can facilitate the air entry into the venous system. This then collects in the right atrium, causing the ventricular arrhythmias, decreased cardiac output, and the cardiac arrest. So the complications associated with the prone position, they are the perioperative visual loss, peripheral nerve injuries, myocutaneous complications like pressure ulcers and compartment syndrome, rare complications like tongue swelling, femoral artery ischemia, ischemic necrosis of the femoral head, hemodynamic complications, prone position, there is a pressure in the abdomen. So the IVC gets compressed, the paravertebral and the epidural veins gets engorged, and the bleeding in the surgical field is there. And sometimes because of the IVC compression, there is postural hypotension, decreased cardiac function, hypoperfusion, and the multiple organ failure. The ophthalmic complication of the prone position are the perioperative visual loss, and then corneal abrasions and the subconjunctival hemorrhage. Perioperative visual loss, the first reported in 1948 by Slocum et al. Incidence ranges from the 0.019% to 0.2%. The increased risk in the patient with the comorbidities such as the diabetes mellitus and the end organ damage, coagulopathy, and the neurologic disorders and paralysis. Ischemic optic neuropathy, most common cause of perioperative visual loss. 89% of the cases of perioperative visual loss, and this is mainly because of the hypotension, blood loss, increase in the orbital venous pressure, and the central retinal artery occlusion, also called as the headrest syndrome. And this is the second most common cause, and the mechanism mainly the thromboembolism and increase in the intraocular pressure from direct compression of the globe. And the third one is the cortical blindness. So, and there are few rare causes of the visual loss. The cortical blindness, the result from decrease in the perfusion of the visual cortex in the occipital lobes. The most common form of perioperative visual loss after the spinal fusions and spinal deformity surgery. The symptoms often improve from the initial ischemic insult without specific treatment, but the complete recovery is rare. There are few rare causes because of some thromboembolic phenomenon. One more complication is the subconjunctival hemorrhage. These are the uncommon ophthalmic complications. It does not cause visual loss. There is impressive appearance may be concerning to the patients, but it is usually asymptomatic and resolved without any treatment. There are some neurological complications like spinal cord dysfunction. Carefully handle the cervical spine during the intubation, as I previously mentioned, during the patient transfer and while positioning the patient. The spinal cord infarction is rare, but reported mainly in the patient with the skeletal dysplasia and the chest wall deformities. So chest wall deformity should be tackled first before dealing with any spine surgery. Then neurological complications like brachial flexopathy, more common than the spinal cord dysfunction, more prone to injury due to the traction and the compression. The main causes are the hypovolemia, hypothermia, diabetes mellitus, and alcoholism. The recovery often occurs, but not always is complete recovery. There are some neurological complications like peripheral nerve injury. The most common is ulnar nerve palsy, and it is mainly due to the direct pressure over the cubital tunnel, or maybe because of the excessive flexion of the elbow or the position of the BP cuff. So make sure that the BP cuff is away from the elbow, and the accidental sudden change in the position of the arm during the surgery. The one more complication is the lateral femoral cutaneous nerve neuropathy. Its incidence is around 24%, but it is reversible. Compartment syndrome is rare. Anterior thigh and anterior tibial compartment is mainly reported. The diagnosis often delayed and missed. The lower pressure in the bony prominences should be maintained in the prone position as well as in the supine and the lateral position. Necrosis occurs mainly after more than 6 hours of the surgeries, and the appropriate padding and the attention of the bony prominences is critical to avoid the cutaneous complications. The massive tongue swelling resulting in the airway obstruction is one of the complication of the prone position. The vascular complications, including the femoral artery ischemia and the vein of the femoral head, is reported in few case reports. Some special considerations in elderly, like their skin is usually fragile, so even while applying the tape, make sure that the skin is not peeled with the tape. Their joints are arthritic, so preoperatively check that there is a shoulder movement for the prone position. Then limited range of movement is possible in old age, and then paralysis, the lifting rather than sliding or dragging. Avoid adhesive taps. You can use the bone foam, and adequate padding for the bony prominences should be taken care of. For a pediatric population, the right size of the bed and the attachment is must. May necessary to use the safety strap. Never overextend the limbs or keep in one position for a long time. Due to small size, the children are prone to and has a great risk of physiological compromise. Appropriate positioning and observation are essential. Few points about the ergonomics during the surgery. So make sure that your posture is straight, and if you are doing some endoscopic surgeries, make sure that the screen is around 3 meters and it is up to the 15 to 45 degrees of the angle. And if you are using the microscope, make sure that your head is straight and you are not bent. The elbow angle should be around 90 to 120 degrees while operating, and the operating table, like patient position, should be at the level of the umbilicus. Approximately the table height recommended is around 66 to 77 centimeter, and you can use the footstool to alternately change the leg position during the surgery. So the take home message is it's not about the technique, it's about the knowledge. If you know what causes complication and how to prevent them, you will be more likely to keep the patient positioning in mind as something you should routinely monitor. Thank you.